Good afternoon, everyone. I'm Janice Whitaker, CGNE Administrator and Community Liaison. It's my pleasure and privilege to serve as the host of the CGNE Seminar Series. This program is being provided by the Teresa Neese and Helen Diskovich Center of Geriatric Nursing Excellence at the Penn State Ross and Carol Neese College of Nursing, in collaboration with the Office of Outreach and Professional Development, the Center for Nursing Research, and the Age-Friendly Care PA Initiative. Today's seminar is entitled Prescribing and Deprescribing in Dementia, Staging, Evidence, 5 M's, and Communication. And it will be presented by Dr. Demetra Antimisiaris. Before Dee is introduced and the presentation begins, there are some disclosures and announcements. Penn State Ross and Carol Neese College of Nursing is approved with distinction as a provider of nursing continuing professional development by the Pennsylvania State Nurses Association, an accredited approver by the American Nurses Credentialing Centers Commission and Accreditation. Participants with a valid RN license who attend the entire nursing continual professional development program can earn 1 contact hour. Partial contact hours are not awarded. The topic of this education is non-clinical, and therefore we did not identify, mitigate, or disclose relevant financial relationships. In order to earn contact hours, Zoom in and out times will be recorded, and the post-event evaluation survey must be completed. Just to make you aware, we are recording this seminar. And if you have a question or a comment for the speaker, you can enter them into the Q&A, the chat feature at the bottom of your screen. You can also, during the Q&A discussion portion, you can raise your hand and be unmuted. Jenny will help us with that. We'll be placing the link for the post-event evaluation tool after the presentation, and we'll give you a few minutes to complete that, or you can do it when you receive the email within 24 hours. But we do ask that the evaluations be completed within a week, and within about a month, you'll receive your certificate. If you have any questions about that or anything else, you can reach out to us at cgne@psu.edu. Next, I'd like to introduce Nahida Akhter, one of our CGNE graduate PhD student affiliates. She's been an active participant of various center activities, including serving as a volunteer at the Memory Cafe component of the new Living with Dementia community education program just yesterday. And when she debriefed with me after, she was absolutely beaming about the experience. Nahida shows her passion for older adults in everything she does, and we're thankful for her today for introducing our speaker.
Thank you so much, Janice. So Demetra Antimisiaris is a board-certified geriatric pharmacist, fellow of the American Society of Consultant Pharmacists, director of the University of Louisville Frazier Polypharmacy Program, and assistant dean of CME and associate professor at the University of Louisville School of Medicine and Public Health. The Frazier Polypharmacy Program is dedicated to multi-stakeholder education and collaboration to empower management of polypharmacy. Her work includes multi-stakeholder targeted CE book chapters, undergraduate and graduate training, clinical percepting, and NSF, NSA, and NIH funded research. She serves on the advisory boards of the Kentucky State Department on Aging and Independent Living, as well as the Polish Ministry of Health Medication Management Initiative. Dr. Antimisiaris' current work focuses on systematic drivers of polypharmacy. So let's welcome Dr. Antimisiaris.
Thank you for the kind welcome and invitation to present this material to you. We were talking earlier about how my nurse scientists and my nursing colleagues are so fantastic when it comes to medications. So I hope this topic is meaningful. Let's see if I can get the screen sharing correct. Yeah, here we go. Okay, can you guys see?
Yes, looks good.
You know what? I'm on the right screen. Let's see.
Yes.
Okay, great, great. All right, so as mentioned, our talk today is about deprescribing and prescribing in patients with dementia. Our learning objectives include implementing tools to estimate life expectancy, identify types of medical evidence for prescribing and deprescribing, apply medical evidence on prescribing and deprescribing, and discuss the importance of stakeholder communication when prescribing and deprescribing outside of the mainstream clinical practice guidelines. The best way to talk about this subject is to start with a case. And this is Miss Polly Pharmacy. She's 74 years old and she was recently diagnosed with mild Alzheimer's, and she's here for a comprehensive geriatric evaluation. She's very affable and friendly, and she says, just call me Polly. Her past medical history includes hypertension, hyperlipidemia, type 2 diabetes, and insomnia. We find out in talking to Polly a little further that she has been experiencing weight loss, difficulty managing her finances, difficulty with some household chores and shopping, but still independent of most of her ADLs like feeding and bathing, and some IADLs still. Her physical exam reveals her heart rate at 65, her blood pressure 129/79. She's very cooperative, but she's clearly very forgetful. Her physical exam was unremarkable, except for some mild kyphosis. Her tug test, her time get up and go, was about 12 seconds. Her tandem stance, where we kind of see if people lose their balance when we push them a little, showed that she does lose her balance. And her MOCA, which is like the MMSE, was 22 out of 30. Kind of indicative that she does have mild dementia going, but we're going to talk a little more about staging dementia because that's important in deciding medication prescribing and deprescribing. Her HA1C is 6.1% and her T-score is -2.5. Here's her medications. She's got losartan for hypertension, atorvastatin to adhere to diabetic guidelines. She's taking glipizide for diabetes, metformin for diabetes, tolterodine for overactive bladder, ginkgo for poor memory, and NyQuil for nasal congestion. Polly says, Doc, I'm starting to have difficulty keeping up with my pills. So she has some insight. And she said, do I really need all of them? And so as the provider and the healthcare practitioner, what would be the first thing that would come to your mind as something that we can definitely deprescribe for Polly? I guess most of you would recognize that ginkgo, through most of the medical literature meta-analysis, is shown to be ineffective for helping memory. And NyQuil is actually very risky because it's strongly anticholinergic. So we can help Polly here by minimizing and talking to her about the inefficacy of ginkgo and the risks of NyQuil. But we find out, we know she's got insomnia, and sometimes when we see people taking NyQuil nightly, it's actually for insomnia. So we might want to investigate that further and offer her something else. But then the question becomes, what do we do about all the other meds? Does she need them? For how long does she need them? We know her HA1C is 6.1 and that she's starting to lose weight, which means maybe she's starting to skip meals. So let's first talk about a framework to approach some of these kind of not clear medication prescribing and deprescribing questions. We need to take into consideration at the same time the evidence that we have about medication use in persons with dementia, and then add that to applying the 5Ms, the geriatric 5Ms that AGS has provided us, which is a framework to help us consider what's important when people get older in making decisions, all decisions, not just medications. We want to consider mind, optimizing, cognition and the mind, mobility. We don't want to take medicines that impair mobility. medications, we want to avoid polypharmacy and suboptimal prescribing. And more importantly, we have to think about what matters most, and then to the individual, and then balance that with multi-complexity. So it's not that easy, but this is a handy framework that AGS has provided for us. And then we have to consider how to implement some of these decisions. Any of you know, when you've tried to talk to colleagues who maybe strongly support that her HA1C has to be 5 or 6 or below, and she must take those medications, it's very hard to explain why you might want to deprescribe. So let's start looking at evidence. What kind of evidence do we have? We have expert consensus. We have observational studies. We have deprescribing trials specifically for persons with dementia. And then we have randomized controlled trials that do not target persons with dementia. So let's start with expert consensus. In many ways, expert consensus is extremely helpful because it's where a group of experts go through literature, get together, and concur and agree upon recommendations. So they've kind of done the work for you. That's usually using the Delphi method, where they go through rounds and rounds of agreement to come to a few set of recommendations. And usually when it comes to dementia, expert consensus centers around different stages of dementia. The problem with expert consensus is that, as you can imagine, it's very finite. Takes a lot of time and energy to put these together, and they're only put together maybe once every few years. And meanwhile, there's 20,000 prescription products on the market and growing, and over 300,000 over-the-counter products. So the expert consensus is great, but it's limited. Stop Frail version 2 or version 1 is an example of an expert consensus paper. Also, the Beers criteria, the start and stop criteria, those are all expert consensus. So let's take a quick look at an example in Stop Frail. Stop Frail are recommendations about medication use in people who have very limited life expectancy. Like, you wouldn't be surprised if they passed away in the next 12 months. So the emphasis in Stop Frail is really on shared decision-making and ethical considerations. They go over 8 therapeutic categories, but it's also important to remember that these expert consensus change over time as the evidence changes. So Stop Frail version 1, when it came to preventive antibiotics for urinary tract infections, did not endorse that idea because they found no firm evidence, whereas the latest version in 2021 actually did endorse that practice because the evidence had changed. So keep in mind, with expert consensus, you have to consider when it was written and what the canon of evidence is at that time, and then maybe another version came out. Let's talk about observational studies. When it comes to persons with dementia, or the unique individual condition that would not be studied in big randomized controlled trials, observational studies at least provide us some signals to help us with a little bit of evidence to think about problems. So with dementia, most of the observational studies are mining records about anticholinergic use, psychoactive medication use, and applying that to whether these are safe or not safe or recommended in persons with dementia. An example might be the anticholinergic studies that are growing in number, that when you're exposed to anticholinergics for over a lifetime, you have a higher risk or a higher association with having dementia. So that's an example of an observational study. So that kind of tells us that anticholinergics are truly very dangerous for the mind. Again, they're limited because they may or may not apply to the individual. Examples of meta-analysis and observational studies and big data summaries could be found, as you know, with the Cochrane reviews. And I just wanted to point this website out to you. It's really kind of a cool website. It's the Cochrane Dementia and Cognitive Improvement website, and it's at dementia.cochrane.org. And you'll see listed different Cochrane reviews about different pharmacological and non-pharmacological interventions for dementia. For example, you could look at the evidence on acupuncture for vascular dementia or animal-assisted therapy for dementia. It's really kind of a neat website. And a lot of that is just big meta-analysis, observational summaries. What about deprescribing trials in persons with dementia? There have not been many. Most have been done in the long-term care setting, so that's advanced stage dementia, mostly involving psychoactive medicines and Alzheimer's treatments. And they really don't show any evidence that separates from placebo, even if they're randomized controlled deprescribing trials, and they're really good science, because as you can imagine, the long-term care patient is highly individual. So it's really, really hard to show the effect of one intervention on two similarly matched groups, because they're not really that similar at that stage. The nice thing is that there are a lot of new deprescribing trials for persons for dementia done in patients that are community dwelling and younger and earlier stage going on right now. My colleague Noel Campbell up at IU has a very long-term study looking at deprescribing anticholinergics in people with early dementia. It'll be very interesting to see how that turns out. Okay, now randomized controlled trials. This is the canon of evidence from which we get our clinical practice guidelines. And as you know, these studies are typically new drug sponsored by pharma. Oftentimes they exclude persons with dementia. Multimorbid patients are also typically excluded from these trials. And usually these trials only focus on one disease. Remember, when we're trying to understand what to do in terms of medications for persons with dementia, we're dealing with multimorbidity and a lot of different conditions all at once. So it's really hard to apply this data to our individuals with dementia. However, one of the most important considerations when applying this evidence is prognosis and lag time to benefit. These are very important considerations for any frail older adult who's multimorbid with limited life expectancy, but especially for persons with dementia, because we kind of know the trajectory of prognosis from mild to advanced and then to death. But whatever evidence you use, we want to be able to apply the 5 M's. And we'll talk about that right after we review some of the oh, I got myself mixed up. Nope, we're going to talk about 5 M's right now. So basically, here's the different kinds of evidence, and then whatever you're using, then you want to apply 5 M's. So how do we apply 5 M's? So medication use in older persons, especially complex, frail older persons, it has to be based on functional status, prognosis, and goals of care. So here I'm going to present to you some tools that we can use for different levels of functional status and prognosis. And we'll start with one tool that can be used no matter what the functional status or prognosis, and that's called the Medication Appropriateness Index. Some of you might have seen that. It is a list of about 10 questions that kind of help you think for each medication the person's taking, whether it's appropriate. It gives you a score, and then that can tell you, maybe this medicine is appropriate or not. But let's start with how do we apply some of our medication analysis tools to the person who's very functional with greater than 10-year life expectancy. And, all of us have seen patients who are 80 years old and climbing mountains, and then we've seen 60-year-olds who are very impaired. So we're talking about the very functional older person who's very active. We want to apply normal chronic condition guidelines to this patient. We want to use prescribing optimization software and medication reconciliation as software, because we can kind of trust that, because they are tested and apply to the young, healthy, middle-aged adult. And this older person who has greater than 10 years of life expectancy, we want to treat them like, a middle-aged adult in terms of criteria. The start and stop criteria, which is like the Beers criteria, but this one tells you what you should be using if you haven't thought about it. For example, anticoagulation for somebody with AFib, or what you should stop. when you're using this criteria on this very functional patient, we want more emphasis on starting medicines that might prevent poor outcomes down the line. What about the vulnerable older person with mild impairment? So this one person has a little bit less life expectancy, and we'll use the start-stop criteria with a little more emphasis on stopping medicines that can cause harm in the near term and over the long run. Beers criteria also, Beers criteria mostly is warning you about medications that should probably not be used because they're somewhat inappropriate. And so for the vulnerable patient, we want to use Beers and start and stop, with an emphasis on deprescribing. There's also a website called the Canadian Deprescribing Network, which I would refer you to. It has really handy tools on there and a lot of information about different medications that should be considered for deprescribing, and it talks about how to deprescribe them and what's the evidence. An example might be PPIs. The Canadian Deprescribing Network has a lot of information on PPIs. That surely is being updated right now because the American Gastroenterology Association just came out with pretty strong evidence that PPIs maybe aren't as bad as we think. So keep an eye on these resources because, like I said, they change over time, but these are some tools you can use. What about the frail older person with advanced stage disease? We already talked about the Stop Frail. And there's another tool called MedStopper. Again, if you Google, you'll find MedStopper, and that's linked to the Canadian Deprescribing Network. These are all handy tools to know basically how to deprescribe. Less is more in the frail older person with advanced stage disease. As you get through that spectrum of functional towards vulnerable and frail, people tend to go in and out of episodic care more frequently, and we want to keep a close eye on medication reconciliation during transitions of care because that increases as a person becomes more frail. How do we know what stage a person's at? There's a tool for that too. The prognosis tool, which is a website hosted by University of California, San Francisco. It has a lot of staging and prognostic apps, you might say, or tools that you can use. And we'll take a look at those. And when it comes to dementia, oftentimes dementia patients are excluded from these tools. So we sometimes want to validate whatever we find on e-prognosis with additional dementia staging tools, and which we'll talk about here in our next slide. Excuse me. Getting over a cold. It's always fun this time of year. So let's talk about the Clinical Dementia Rating Scale, or the CDR. This is a really good tool that you can find at Washington University's website at the links below. And let's try to apply this tool to Polly. We know that Polly has slight forgetfulness. She's fully oriented, but she has some difficulty with time. She has slight impairment with judgment and similarities and differences. Her community affairs, she's becoming increasingly unable to function independently. So we're gonna give her a 1 there. Her home and hobbies, her family informs us that she's starting to give up some of her home and hobbies, and she needs prompting for personal care, but she can still do personal care. Her overall CDR rating is a 1, which puts her at the mild stage of dementia. Mild dementia is correlates with the Clinical Dementia Rating scale of 1, minimal status exam of 10 to 20, a MOCA of 18 to 25, and the person will have difficulties with producing words, remembering names, performing tasks, recalling materials that were just read, losing or misplacing valuable objects, and planning or organizing. So let's go back to Polly's pills. How does this information impact our decisions about Polly's pills? Well, we want to focus on lag time to benefit. And we need to always ask ourselves, will the medication help? When will it help? And how much will it help? So this paper by Lee and colleagues kind of summarizes how to look at lag time to benefit. If life expectancy, you first have to have the patient's life expectancy and then consider the lag time to benefit. If life expectancy is greater than the lag time to benefit, the intervention may help. If it's less, it's more likely to harm. And if it's equal, it becomes a close call. That's where the what matters most in the 5 M's comes in. Prognostication tools found on ePrognosis also include, in addition to the one that we're going to look at next for Polly, something called the Mitchell Index. This is more for people who are with end-stage dementia. It estimates 6-month survival in nursing home residents. So we'll take a look at this a little later. But let's go back to Polly's life expectancy right now. Here's just a little recap of her presentation. And we take this information and we put it into the Lee Index, which is in the ePrognosis website. And it gives us information that her life expectancy is about 9 or 10 years. And with that, we can start looking at the evidence for some of her medications. We know she's got cardiovascular medicines and diabetes medicines. And then she's got the tolterodine for overactive bladder. Let's look at the evidence about time to benefit for antihypertensives, because that's the reason she's taking her losartan. You need to treat somebody for 1.7 years at intensive blood pressure management in 200 older adults to prevent 1 stroke. So if we consider, which we'll talk about later, that Polly really just wants quality time with her family, we do want to prevent strokes. So managing her blood pressure sounds like a good idea. Statins, you have to treat 100 adults for 2.5 years with a statin to prevent 1 major acute coronary event. So again, this is something that probably would benefit Polly. Glycemic control. Remember, we said her HA1C was 6.1. Y'all are pretty familiar probably with the numerous trials that kind of showed that when somebody becomes quite old and frail, sometimes the oral anti-glycemic medications can cause more problems than good. And that's how we came up with the kind of relaxation of guidelines for people over 80. But Polly's not quite over 80. She's got limited life expectancy. So let's take a look at the evidence about time to benefit. Intensive glycemic control does not reduce major macrovascular events in older adults for at least 10 years. We're talking the eyes and the kidneys. Intensive control does not lead to improved microvascular outcomes for at least 8 years. But also at the same time, there's a 1.5 to 3-fold increased risk of hypoglycemia, which can be, as you know, very harmful to the brain. You kill brain cells with every hypoglycemic episode. So if we think about all this evidence together and her life expectancy, and as I said, we'll talk about her goals of care later, maybe tight glycemic control might not be a good idea for her. Bisphosphonate treatment. Remember, her T-score was minus 2.5. The time to benefit with bisphosphonate treatment is only about a year to prevent 1 non-vertebral fracture per 100 postmenopausal women. We also know she had some kyphosis. So sounds like maybe adding a bisphosphonate makes sense for her. So again, let's go back to her presentation. And with that, we have gone to ePrognosis. And I want to point out another feature at ePrognosis, which is a time to benefit estimator, not for all conditions, but for some of the more important questions that we have, like cardiovascular management, endocrine topics like bisphosphonates and glycemic control, and some of the screening, colorectal cancer, mammography, etc. You'll see that in Polly's case, and if you look straight down from the 8 to 10 years of life expectancy, blood pressure control is a good idea. It's in the green. Statins are still a good idea. Intensive glycemic control is a good idea, but if she's maybe not eating, we can ease up a little bit. Bisphosphonates, a definite green. Colorectal cancer screening, yeah, maybe. Mammography, maybe not so much, etc. And with time, her life expectancy will become lower. And you can see that these different items change. They all mostly come into the red. That means deprescribe some of those medications. So now that we know what to do with her cardiovascular and her diabetes meds, what do we do about the bladder med? What do we know about tolterodine? It's strongly anticholinergic. It's not supposed to go and cross into the brain. It's designed not to. But for people who are old, frail, or have brain pathology, medications can cross into the brain. So tolterodine, an anticholinergic bladder drug, is a little bit risky for her. Also, you'll notice that she's not been treated with donepezil. So we're going to consider adding alendronate, donepezil, and calcium and vitamin D. And the friends, by the way, would like to know, with her new diagnosis, what about the new Alzheimer's medicine? So as you know, aducanumab is not recommended by the American Geriatric Society. So there's a lot that goes with it. You have to get MRIs all the time. It's very expensive. It's only for a very early stage intervention, and the evidence is really not that strong. So that one we're not going to consider. But let's think about how to apply the 5 M's to that tolterodine. We want to optimize her mental and her cognitive capacity. We want to not hurt her mobility. Anticholinergics can increase the risk of falls tremendously. We don't want to increase her polypharmacy or use medicines with severe side effects. And we want to consider what matters most to her and her balancing with multimorbidity. So Polly is at increased risk of delirium because she has dementia. So anticholinergics are not a good idea. Her TUG score was 12. She has some loss of balance. And she has a low T score. So she has osteoporosis. Falls can be very dangerous for her. We should probably think about not using tolterodine because of that. She wants a lower medication burden. And she would like to improve her memory and have quality time with her family. That's what matters most to her. So the decision was made to discontinue the tolterodine. And anytime you discontinue something, you want to try to offer something that's known to be effective. And time toileting is known to be effective for overactive bladder and incontinence. But then we've got to engage the patient and explain all that, right? It's very difficult to deprescribe medicines that patients perceive work and are safe. So you have to kind of reframe the medicine for the family and caregivers. The key principles when it comes to thinking about deprescribing is that we need to know what matters most. And when it comes to dementia, we have to get that down as early as feasible after the diagnosis, because eventually people are unable to express what matters most to them. So it's very important to document as early as possible. Also, in terms of ethics and legal considerations, prescribers have no ethical or legal obligation to prescribe or renew medications that will no longer benefit or might harm the patient. We just want to be kind of clear about that. And Dr. Tan, who I presented this with, was very clear about that. So now that we've looked at how to apply the 5 M's, let's take a look at practical steps for medication management. Let's put all this together. We want to stage the person's life expectancy. And okay, so we're thinking about her Fosamax or alendronate, bone density treatment. We know that she's got mild dementia. She might live 8 to 10 years. We want to determine what matters most. We know that she wants to have time with her family. So a hip fracture would, really cause her some serious problems and ruin what matters most to her. We look up the data and information about the medication that we're considering to either deprescribe or prescribe. In terms of bisphosphonates, we know that the time to benefit is less than life expectancy for her. And we want to minimize side effects and dosing. So she might have trouble swallowing, or she might have trouble managing an oral pill. So we might consider an IV infusion just to take care of it and not make it something she has to manage. We also have to get a dental consult. And then we have to discuss that with her caregivers and her physicians. And we decided to add that for her and then recheck her BMD in 1 to 2 years. So let's catch up with Polly 5 years later. Now she's got a CDR of 2. Her MoCA's gone down to 10. She has a lot more impairment in terms of controlling bladder. She's wandering. She's getting lost. She's getting personality and behavioral changes. And so she has mild dementia at this point. And 8 years later, we find her with a CDR of 3, a MoCA of 3. She did end up going to the nursing home with a hip fracture. So we can try a treatment, but it may or may not be effective depending on, each individual. She's it almost needs full care. And then eventually she gets very late stage and she does need total care. She can't recognize loved ones. So let's take a look at how we approach her as she advances. The Mitchell Index, if we were to plug in, her information as an older person with later stage, it would tell us that her 6-month risk of mortality is upwards of 60%. So that kind of brings us to the question of, do we deprescribe her dementia medications? And basically, individuals who would be suitable for deprescription of cholinesterase inhibitors and memantine are those who are taking it for inappropriate indications, or those who never experience benefit, or those who appear to no longer benefit. Clearly, at advanced stage dementia, these medications are not of any benefit. The person's in full care. It's just another medication that can potentially cause side effects. However, there is some interesting data that has recently been published for the use of cholinesterase inhibitors in earlier stage dementia. And this longitudinal study of 5 years found that cholinesterase inhibitor users had higher MMSE scores and a 27% lower risk of death over 5 years. And when you look deeply into the study, you see that these are early stage with early intervention with cholinesterase inhibitor use, and then that's carrying it forth 5 years. So maybe it would help somebody through about moderate stage dementia. So cholinesterase inhibitors are, as long as they're harmless, they're worth keeping, it looks like. But later on in advanced, then they're worth deprescribing because they're not doing any good. So we've now at late stage deprescribed all her meds that she was on and what she had picked up along the way: sertraline, donepezil, memantine. And now her caregivers convey that she grimaces and vocalizes when moved. She seems in pain, and her family and friends just want her to be comfortable. So now we're going to prescribe hydromorphone and Senna. So how do we talk to other people involved in her care to implement some of these decisions? We have to form relationships, and we have to use good listening skills and do so with respect. So as mentioned earlier, endocrinologists might really push to get her HA1C low, even if she's very old and frail. We have to respect that they're not doing that with harm as a goal. They're doing it because they think that that's what's good for her. So it's upon us to kind of educate people about our logic and what we're doing and document as best we can with evidence and guidelines. We have to also understand the life context and priority about the person. I'll let you read through these in the interest of time. So let's go back to Polly, for example, and try to align the deprescribing with what matters most and then frame it as positive. So Polly, you told us that being able to stay independent and spend time with your family is important. In order to help you do this, we want to talk about discontinuing a couple of your medicines. The NyQuil you're taking has several bad side effects that may interfere with you doing what matters most to you. This medicine can cause dizziness, falling, and worsen your memory and thinking. Another way to discuss deprescribing would be to, for example, the way we might talk to her about her glipizide. The evidence from Ariel Green, that's the framing it positively, may not work when it comes to deprescribing oral hypoglycemics or any hypoglycemic when somebody's worked hard all their life to try to manage their diabetes. So let's approach Polly and tell her, Polly, I know that you've done a great job with keeping your HA1C on track. We're also concerned about the side effects of glipizide, and there are other ways to control your blood sugar that have less risk of adverse effects and will help you meet your goals, your life goals. So here, what you're doing is you're talking about the side effects. So some evidence has have demonstrated that when we talk to people, we want to frame things positively. But sometimes one of the biggest concerns of our patients are side effects. So we can positively frame why we want to avoid the side effects And that seems to work pretty effectively. There are barriers and facilitators to deprescribing. You all know that, I'm sure. Patients see it as a sign of giving up. Providers have, policies and drivers of medication use. That's kind of what I study. And so we have to take all these into consideration. Like, for example, providers have incentives to get people to HA1C goals. And you have to help them document why we're not having those goals, for example. In summary, we need to consider the evidence for deprescribing and prescribing in persons with dementia. And always the 5 M's can help us guide decisions in clinical practice. Consider life expectancy and time to benefit, and communicate to align care with what matters most. Thanks so much for your time. I'm sorry I'm running a little late, I think. I'll hand the screen back over.
Oh, thank you so much, Dee, for this outstanding presentation. I love the way that you applied the 5 M's to medication use and management, and the wealth of resources and tools you shared with us and how they can be implemented. I also enjoyed how you applied this information to the case study. And the name of the patient was also fun. They're very creative. So thank you so much for an outstanding presentation. We will return for some Q&A and discussion, but we want to take a brief pause to invite our participants to complete the evaluation for this session. As a reminder, this is a requirement for registered nurses seeking contact hours. But we also appreciate that every participant provide feedback to us, not only on the seminar, but in how we can continue to improve our series. The link has been placed in the chat, and we will give everyone about 3 minutes to complete the evaluation. As a reminder, another requirement for the contact hours is to attend the full session. So please return after you've completed the evaluation so we can enjoy some more time with Dee sharing some questions and responses. Okay, I'd like to resume our seminar. If you're still working on the evaluation tool, please feel free to continue that process. But we do have, first of all, a lot of really positive feedback, Dee, in the chat. I hope you've had a chance to take a look at that. So many thank yous and much appreciation for this outstanding presentation. I also want participants to know that we have experienced a little technical glitch in that your name might not be showing when you enter a comment or question in the chat. So if you can type it in along with your comment or question, that would be helpful. We do have a comment related to that this individual agrees that going to a specialty office, the goals are to work on getting the abnormal back to a normal state. And some physicians have decision trees they follow to correct the event or abnormality. This person feels that education to the patient and families to bring this up to the physician has a better outcome than coming from the nurse. And I know that you did respond to that comment, Dee, but if you could share your thoughts aloud with the group, that'd be great.
Yeah, I guess, I appreciate that comment because, again, my favorite collaborators are my nurse colleagues because you all know, you kind of observe the dynamics, right? Rather than just, I think the physician doesn't really observe some of these dynamics, but you also know that it's very hard to kind of tell a physician who is driven by quality measures that they have to make. That's that systemic driver of polypharmacy. It's very hard to explain these things. But if it comes from the family, what it does is it gives the provider the permission basically to not use the medicine. It gives them something to document. And if you can empower the family to bring good evidence to the physician and explain, maybe there's no time to benefit, that just helps them have something to kind of get them off the hook, basically.
Yeah, it's excellent points. Thank you for sharing that. We have a couple of comments related to a desire for the PowerPoint slides or materials, which I certainly understand. We did speak with Dee prior to the presentation about that possibility, and because the authors involved in this are pending a publication, we're not able to share the slides at this time. But if you are, if we're able to do so in the future, please, we'll be happy to do that. Just send a note to cgne@psu.edu to let Jenny Rank know that you're interested. We'll, collect a list. And when it's possible to share the PowerPoint slides, we'll do that in the future.
And the publication.
And the public, yes, the publication, absolutely. Great.
And you can always see this recording too.
Yes.
I know it sounds kind of cheesy, but what happens when you submit a publication is it becomes the property of the, like, American Geriatrics or whatever. But once that's done, then doesn't matter.
No, but thank you for bringing up the fact that we are recording this seminar too. And we always post our CGNE seminars recordings on YouTube. So that's another way to review the information again. Diane Barish is asking, for nurses who may not have a prescribing or deprescribing ability, do you have suggestions for advocacy or communication steps to take if they feel an individual that they are providing care for may be on a high-risk medication that could potentially be deprescribed? And of course, she's thanking you for a great presentation as well.
Oh, you guys, I'm just humbled. Thank you very much. And thanks to Dr. Fick and Dan too. Yeah, hey, welcome to my world as a consultant pharmacist in a nursing home where, I've identified, something that needs deprescribing, and, how do you advocate? The best way to advocate really is to identify the problem, identify the evidence that supports why you want to make the change, and then identify how it applies to that individual. And if you can, provide them references. So, for example, if somebody's taking a strong anticholinergic and you feel it's a threat to the patient, the Beers criteria has the evidence. You cite that Beers criteria. And if you do that, it makes it, in other words, you're always wanting to make it easy for the prescriber to kind of think, document why they're deprescribing something.
Yeah, and I was actually, as a former director of nursing, I was also thinking, as you were describing that, not only advocating to the physician or consulting pharmacist, but making sure you have the nursing documentation to support your concerns, right?
Yeah. It's kind of interesting. I work with the Polish government. They're implementing a pharmacist-based like medication management in the community program. And I've done a lot of seminars for them about like how to talk about deprescribing, because they have the same problem.
Mhm.
And so it's kind of this checklist, like, here's the problem, here's the evidence, here's how it applies to this person. And by the way, here's a reference.
Right, yeah. But I know it also helps, especially with the long-term care regulations, to make sure that, nurses, if they're seeing side effects, if they're seeing, areas of concern,
Yeah.
that they're documenting that. And that's not always the case, anecdotally, they know that and they'll share it verbally, but we need to make sure that documentation supports it.
Good
So-
point. I have noticed that nurses intuitively know when a medicine's causing trouble. But yes, keeping a log document, way to go.
Any other questions or comments? Lots of positive comments, again, related to your presentation and the tools and resources you shared, as well as, your sharing of how to implement those things.
Glad to share.
Eric is asking or mentioning, assuming you're familiar with the social movement of age-friendly care, as you talked about the 5 M's,
Mhm.
what is your perspective on the age-friendly health systems movement and the 4 M's?
I am familiar with the 4 M's versus the 5 M's, and really what that turned out to be was kind of an international difference. Like they kind of came about these ideas at the same time because everybody goes to the same conferences. So, Canada had, I think, the 4 M's, and then AGS America had the 5 M's. And the really big difference is that multi-morbidity piece, but the 1 to 4 M's is the same. As far as age-friendly health systems, so I work in a health system, but not that much. I do more research these days with data, but I sadly am not seeing the age-friendly health system being implemented very well. I've been doing this. I came to academia about mid-career. So for the past 15 years, we've been talking about age-friendly emergency departments and post-discharge care. And it really kind of comes down to reimbursements.
Mhm.
I just think that is a great framework. If you want to go talk to your health administrators, I've moved my program to School of Public Health on purpose because I want to understand how the health administrators think, because that's what's driving polypharmacy, right? And I've noticed that and this is not a slam against them. It's just their primary goal is business.
Mhm.
So we, as usual, have to go and educate our colleagues.
Right, and show evidence of outcomes, including positive outcomes as well as adverse outcomes in relation to age-friendly care or not implementing age-friendly care, and including financial outcomes, right? That's,
Yeah, exactly. Think about the financial power of doing age-appropriate care.
yeah, the cost incentives.
Yes.
Yeah. And Erica adds, we're doing this in the community as well. So
Wow.
the movement that we've been involved in, was initiated by IHI and others, and started in acute care. And then the grant that we've been implementing was primarily focused on primary care settings, and now there's a component related to long-term care. So
is that a Hartford? IHI.
IHI.
Yeah.
IHI.
Okay, I gotcha.
And, yeah.
Good work, you guys. We don't have enough institutions that are kind of got that critical mass. Good job.
Thank you for that feedback. Any other questions or comments for Dee at this time?
Please feel free to email me anytime. I'm glad to help with any medicine questions.
Yeah. One of the things I was thinking about as go ahead, Jenny.
I was just going to say we have another question in the Q&A from
Oh.
Diane Barish that asks, do you see a potential alignment of non-pharmacological interventions such as nutrition or physical activity to support deprescribing?
Mm.
I'm glad you brought this up because we did not emphasize this enough. There's, as you probably know, exercise is the one thing that helps dementia. It's like the only evidence-based thing that helps dementia. So yes, yes, and more yes. I agree. Time toileting versus medications, activities and engagement that are appropriate for the person's, level of engagement instead of psychoactive meds. I think that's very important.
Yeah, non-pharm approaches as much as possible.
Yeah.
Right. One of the things I was thinking about when you were talking about hypoglycemia, you shared the concern of neuronal cell death as a relation to, low blood sugar episodes. I was also thinking about increased risk of other problems for older adults like falls,
Right.
yeah.
Confusion, falls, yeah.
other things.
Yeah, especially if they're living in a institution where, I think sometimes institutions don't think about that.
Yeah, great point. Yeah. All right. Well, thank you again for this amazing presentation. We really appreciate your time and effort. This was invaluable for us in terms of really connecting it with age-friendly care, as well as finding ways to improve care for older adults in relation to medication management. So thank you for sharing your expertise with all of us. And as a reminder to our participants, if you didn't fill out the evaluation during the seminar today, you have up to a week to complete it, and we do appreciate your feedback. And we will be following up with RNs that not only participated but completed the evaluation in terms of your contact hours. So, and we hope that people join us again for our next seminar on next week on September 29th, enhancing preference-based person-centered care for older adults with multiple chronic conditions via implementation science by Drs. Abbott and Van Heidsma. So thank you again, everyone, and have a great rest of your day.